Welcome to PCR London Valves 2025. My name is Lukas Stolz from the LMU University Hospital in Munich, and it's my great pleasure having Rebecca Hahn from New York with me. And we are going to talk about the evolving field of transcatheter tricuspid valve interventions. Now that we have a broad variety of therapeutic options coming up with edge-to-edge repair and transcatheter replacement, it's not always an easy decision which patient to treat with which device. So my first question would be, do you think it's necessary to reduce TR as much as possible? So should we aim for mild tricuspid regurgitation in every patient?
Yeah, that's a great question, because I think much of the data that's been presented really frames the efficacy in terms of moderate tricuspid regurgitation. But I think we all know now, with further results that have come out with many of the registries, that if we want to improve hard outcomes of mortality and heart failure hospitalization, we will need to get the tricuspid regurgitation down to mild. So I'm a pretty big believer that the goal really for these device therapies should be mild tricuspid regurgitation.
All right, I absolutely agree. I mean, we've seen data that report the more we reduce TR, the better our symptomatic outcomes are, the more reverse remodeling we see in those patients.
Correct.
So are there any tools that could guide us in our decision making, whether we're going for TEER or for TTVR?
Yeah, I think a lot of the early data studies on T-TEER were able to identify predictors of being able to get down to moderate. Now, getting down to mild is another story, but probably the similar predictors. And one of the scores that has been looked at is the GLIDE score. So the GLIDE score looks at the gap, the location of the jet. Typically anterior-posterior is a little bit easier to reduce. And then image quality, so highly dependent on imaging, remembering now that we have three-dimensional ICE is available now throughout the world, and has really helped us, I think, eliminate imaging as one of the barriers to getting a good result. And then the density of the cords. Now, we just did a study with the University of Padua looking at anatomic specimens, and the density of the cords is tremendous. The chordal free zones are limited, and so most of the tricuspid valve leaflets have very dense cord, but you also have to deal with the cords that may be attached directly to the septum and then some intercordal connections. So the density of the cords, I think, is probably still an important thing to think about. And then the en face morphology. This speaks a little bit to the morphology that we looked at when we were trying to speak the same language with our interventionalists during the T-TEER procedures, because we ended up seeing so many leaflets. And so we were able to show that in a large percentage of the patients that we saw, there were more than 3 leaflets. And so that type of complexity is also going to possibly reduce the ability to get down to mild.
Okay, fantastic. So we have tools that might help us deciding whether we are able to reduce TR effectively by TEER. On the other hand, we have different safety profiles and different profiles of potential adverse events for TEER versus TTVR. What do you think about that? Do we also include those parameters into our clinical decision making?
Oh yeah, I think so. Remember, we have a bleeding risk with the TTVR devices. They're bigger devices, and in the initial trials the bleeding risk was fairly high, but in part because of the protocols that were in place at that time, trying to balance the risk of thrombosis with bleeding. And so we now know that we can control anticoagulation a little bit better, and therefore reduce the bleeding rate. So I think that that's possible. We would advise that these patients that get a TTVR be on anticoagulation. And so again, if you have a patient that cannot have anticoagulation, it might be a consideration for using a device that doesn't require it. We also know that there's a pacemaker rate for the patients. And so in pacer naive patients, the rate may be as low as 14%. We're not sure. That's in the most recent real world data. But it's a reality. And so you might want to consider that in your patients. It's not really an issue for T-TEER devices typically. And then there are those patients that already have a pacemaker in place. And those are a little bit of a double-edged sword. If you have a pacemaker in place that's causing tricuspid regurgitation, you're not going to be able to get down to mild as easily as if that pacemaker were just an incidental finding. And with TTVR, the device is agnostic to that. It doesn't care. And it will get the regurgitation down to mild or less in 95% of cases. So the issue there is whether or not you have any pacer dysfunction. And it seems as though that rate is real but low.
Yeah, absolutely agree. So a lot of points to consider. I think in summary we can say that it's absolutely crucial to reduce tricuspid regurgitation as much as possible. Then to consider anatomical factors when deciding whether to go for TTVR or TEER, but also potential adverse outcomes. And then, of course, to see the patient as a total, considering other echocardiographic findings, comorbidities, and just the overall prognosis. And I think with that, we can achieve the best outcomes for our tricuspid patients. Thank you very much, Rebecca.
Thanks for having me.